You got a what? Okay, so the objectives, I broke it down into a few categories. So going over some spine terminology, again, what are the surgical options? It's, kind of a plethora of options. And then, a little bit about the procedure itself, what we think about, the anatomy, and then I also added in some of the post-operative rehab issues that we might come across, some post-op complications and risks. And again, majority of this is focused on lumbar fusion. So we break all these words down regarding the lower back into all these S words, which I'm sure most of you have heard before, but spondylosis, spondylolysis, spondylolisthesis, stenosis, discectomy, fusion, and then total disc replacement. So these are, the first four are basically the pathology of what the patient has, and we'll go over each specifically. So the surgical options end up being based upon what the patient presents with. So does the patient just have back pain? Do they have back pain and leg pain? Do they have leg pain only? Do they have leg weakness, leg numbness? Do they have deformity? So do they have a scoliosis? Are they hunched forward? Do you require to decompress the nerve? Or can you just fuse the back? So what are the differences, and why do we choose to go one direction or the other? That's the main goal of this presentation. So spondylosis is basically just a cool word because spine people think they're the smartest, and just adopting the fact that it's arthritis, right? It's wear and tear phenomenon of the back, and you start to develop that after the age of 35, whether you like it or not. And I think there's an enormous genetic predisposition to this. So if your family members have had it, commonly now we've seen patients in their late 20s, early 30s, and then you ask these patients like, hey, how's your mom and dad? And it's likely they said like my parents have had an operation, or they had a fusion or decompression. So there's a genetic predisposition that's huge. So this is a normal X-ray. So typically in the office, everyone gets an X-ray. This is a normal X-ray. You got good disc spacing of the lumbar spine, 5 vertebrae. There's no spurring. There's no compression of the segments. Good lordotic curvature. You want your lordosis to measure somewhere in the vicinity of 40 to 60 degrees. And those numbers are super important when you're trying to figure out these fusions, because you don't want to put someone into kyphosis or flatten their back out, because that can cause bigger issues. So this is a picture here of just, a lot of wear and tear in the back. As you can see, there's multiple segments that are narrowed. You get some spurring off the front. These spurs off the front really are meaningless in terms of, causing issues, because there's no real nerves that are in the front of the spine per se. You get the, blood vessels, but those really don't impact these spurring issues. And this is just another picture of an AP where you can get a whole bunch of lateral osteophytes as well. And you get a little bit of what we call a fractional scoliosis, where it's not super linear. There's a little bit of segmental listhesis. So what do these patients present with? It's like what some of us deal with on a daily basis. Some diffuse low back pain. Maybe it's a 3 out of 10. Maybe it's a 10 out of 10. They get some sitting intolerance where they can't sit for too long. Their activity-related pain. The more I do, the more I bend, the more I sit, the more I lift. My back bothers me. But it's kind of your run-of-the-mill lower back pain. Spondylolysis is typically a congenital or a traumatic phenomenon. So that's where you actually have a stress fracture or a break in the vertebral body. So you basically get a disassociation of the front of the body with the back lamina and facets. And that can allow the spine to later on slip forward, which is then a spondylolisthesis. This typically occurs at L5. It's very, very common in athletes, more so males than females. Typically, these kids are presenting somewhere in the vicinity of 16 to 18. They were playing football or they were playing some kind of sport. It's a hyperextension injury. So you hyperextend the back, and there's like these loading forces that go through the facets, and they break these small bones called the pars. It accounts for 50% of lower back pain in kids. So it's almost a guarantee, patient, young athlete has a stress fracture, which is called the spondylolysis in the lower back from sports. Some of you may have heard about the Scotty dog appearance. So you get a crack in the pars defect. That's the stress fracture. That's what disassociates the back of the spine to the front of the spine. and we shoot these X-rays called obliques to see if there is a break in the neck. And on the left side, you can see that little crack where it says Scotty's collar. That's where the fracture occurs, and that's on an oblique X-ray. So we take a lot of obliques in young kids to take a look at that stress response. Here's another picture of a spondylolysis. On the right, the X-ray, you can kind of see faintly where there's a lucency along the pars. Here and over here, you can't really see it. And then the spine did shift a little bit along in conjunction with the disc narrowing. Yeah. So what can happen is if you get a dissociation from the front to the backbone, like you're seeing on both of those X-rays, the spine, that vertebrae can actually slip forward. And so it takes the whole spine forward, and we grade these out of 4. So 1 is 25%, 4 is 100%. So the picture on the left shows a 50% slip. So you can kind of tell that the back of the body of 4 here and the back of the 5 here don't align. So the 4 shifted the whole spine forward. So what do these people present with? Well, they present with back pain, obviously, but because of the slip, you can get impingement of the nerve. That typically is unilateral. People complain of leg pain. They tend to feel better if they forward flex, like if they use a shopping cart or if they sit in a recliner. They extend their back, it bothers them. They can't do a lot of extension type exercises such as repetitive bending. And so that can be a multitude of issues surrounding back pain and nerve pain. Spondylolisthesis, that's the slip. That's where the whole spine moves forward. And this is a super common problem in an aging phenomenon, usually after about the age of 50, particularly in women. Every year or every decade, there's an increased incidence of this. So by the time I see women in their later 70s, probably 85% of them have a spondylolisthesis. So super common problem to present with to the office with lower back pain, and that can cause sciatica. It can cause neurogenic claudication, which means that like the longer you walk, the heavier your legs feel, the more painful your legs feel. Then you sit down and you feel better. You know, that's the general classic story. There's a multitude of why you can develop a slip, from that pars defect to degenerative issues to iatrogenic, meaning you had surgery, you might have taken off too much of the lamina and the facet, and actually the bone slips on itself from surgery. It could be traumatic, dysplastic, could even be caused by some pathologic issues too. So this is just another X-ray showing the alignment. Patient has good lordosis, but you can see at L4, L5, there's a slip there. It's probably maybe 3-4 millimeters. The one on the left is degenerative, so wear and tear. The one on the right at L5S1 is that pars defect, so there's a difference. And we usually get flexion extension views in the office. So we have patients, bend forward and bend backwards, particularly with these slippages. And you can tell that those two X-rays, same patient, that level is unstable. So it's actually clicking every time you move forward, every time you move backwards. So you could imagine pain arising from that feeling of instability there. So this is a patient who obviously had surgery previously, and this is kind of the gold standard of why we really don't like to do fusion. So you get this, welding job of one bone to the other where the screws are, then you increase adjacent segment mechanics, which allows those areas to wear faster sooner. So the next level got super arthritic and degenerative, and then the subsequent level 3-4, you can see how that slipped forward. And so this is a very common problem. We tell patients that after a lumbar fusion, your incidence of developing another disc problem at the next level is about 10%. And every 10 years, that increases by 10%. So if you have these things done in your early 30s, early 40s, it's almost a guarantee you're going to need another fusion. Okay. So, we seem to fuse all these people. And if you're actively working in the OR, you're like, well, gosh, we do fusions all day long. But if you're really thinking about this, fusion should absolutely be the last resort for your family members, for anybody, just because it may not be the last time, particularly if you're of a young age. So similarly as the stress fracture, the pars defect, a lot of these degenerative spondylolistheses have similar symptoms. So back pain, extend backwards, it hurts. A lot of these patients say, well, if I walk for a long time, I got to kind of put my hands on my knees and bend over to get some relief. It can cause nerve pain, leg pain. And so it's a very similar presentation as a pars defect, except for this is a degenerative process that we see in as we age. Stenosis is the one that everyone talks about, right? Like, I have stenosis, I can't walk too far. This is the same kind of patient that says, well, you know, if I use my walker, I feel better. If I don't use my walker, I feel like my back's not holding myself up. So this is narrowing. So you actually get narrowing of the spinal nerves. And I like to tell patients that if you think about the spinal canal as a garden hose, off the garden hose, you have a whole bunch of spaghetti strings, and those all travel through tunnels. And if those tunnels get compromised by, you know, degenerative disease or bone spurring or ligamentous hypertrophy, you know, these nerves get pinched, and that's why people get this clotatory symptom with stenosis, where, you know, they suffocate the spine and then they can't walk long distances. And so their legs feel heavy, they may feel weak, they may feel numbness and tingling, and this becomes a real big issue. And the decline for stenosis is pretty significant. You go from walking like, you know, I've had patients say, well, last year I walked 3-4 miles a day, and today I can't walk around a football field. You know, so it's very, very impactful. So this type of surgery, stenosis surgery, I feel as though is the most miraculous for patients, because these patients have surgery and then all of a sudden they're like, wow, I can walk a mile again, you know, and that's a huge change for these people. So we'll go over a few MRIs and x-rays now. So the picture on the left side is a very patent spinal canal. You can see the, you know, the subarachnoid and the thecal sac there with the nerve roots. On the left side, very open. And then on the right side, you can kind of imagine how it looks like it's pretty narrowed at L3, L4, L4, L5. So this patient, you know, has obvious signs of stenosis. Again, on the left side's normal, this big white circle. Oh, yeah, this big white circle is patent, and then the white circle goes away. So all the nerves are becoming entrapped and compressed, and this is the typical picture of pretty severe stenosis. Similarly here, again, you have the central canal here is just almost blacked out. So this patient definitively would have neurogenic claudication, so difficulties, leg pain, you know, potentially weakness, heaviness, difficulties walking. This kind of just goes over a little bit more about that whole scenario with stenosis. So what do you do for all these people, whether or not you have a stress fracture and you have a spondylolisthesis or stenosis? So it's fairly algorithmic. You know, no one jumps to surgery right away unless there's like gross weakness or, you know, symptoms of quad equina. So most people, in fact, 90% of people go through all the same stuff. So, you know, anti-inflammatories, you know, physical therapy, a multitude of different types of injections. You know, we're pretty good at you know, hypothesizing where these patients are going to be, and, you know, quite frankly, we're pretty upfront, like, hey, listen, some of this stuff you have to go through just because of insurance purposes, right? But for the most part, you know, 85% of people that come into the office with a multitude of these issues, back pain and leg pain, for whatever reason it is treated conservatively. There's only about a 12 to 15% process that population that ends up needing surgery for all of these issues. So what do you have for options? So you have, you know, a decompression or a discectomy. You know, the trend in spine is now leading very much so in disc replacement. It's not hugely adopted in the area, but around the country, there are pockets of huge disc replacement centers. And then ultimately, you know, fusion. And we do these in a variety of ways, a variety of approaches, through the belly, through the side, through the back. And then you start talking about direct and indirect decompression. So direct decompression meaning like you're going in there, you're going to look at the nerve, you're going to decompress everything around it, the ligament and everything, versus indirect. Indirect is when we put these wedges or these cages inside the vertebrae to, you know, jack them up, so to speak. These devices also have calculated in them lordotic changes. So you can put a cage in there that has 30 degrees of lordosis, 15 degrees of lordosis, 8 degrees of lordosis. And that's super important because some of these patients that come up, you know, with all these issues, they have what's called sagittal imbalance. So the reason why they're having a lot of back pain is because their curvature of their spine, the lordosis has changed significantly. So if you don't change those numbers back to normal, these patients will never get better. So there's a lot of calculations, a lot of, you know, a lot of math going on behind the scenes to come up with these, even though sometimes you may think that these guys are just coming in here, throwing in cages and getting out. So, so what's the, you know, what's the choice of the dealer? Well, it's really what they've, basically what have you been educated on? What was your fellowship in? What direction are you trying to go with? What are you trying to relieve? Are you trying to relieve back pain only? Are you trying to relieve leg pain only? Are you trying to relieve both? So having that discussion with the patient as to what are we trying to gain out of this operation is super important. So discectomy or decompression, patient presents, my back doesn't really bother me too much. My leg's killing me. It's typically unilateral, and you've failed conservative measures. You go in there, it takes about a 45 to 60-minute procedure. This is just showing disc herniation at L5S1. The disc herniation is right, all this stuff here that blacks out, and it's this here. So the left side of the screen is actually your right side of the body. So this patient would present with a right-sided leg pain and an S1 distribution. So you go in, you make a laminotomy, so you make a hole in this bone here, you take down some of the yellow ligament, and then you just pluck this piece out. It's about like I said, it's 45, 60-minute operation, instantaneous relief of, your nerve pain, and you move on. It's the more simplest of the procedures we'll talk about. This is just another depiction of an L4-5 herniation. Again, this black stuff is all disc fragment that you can imagine is compressing a nerve here. This is an L5 nerve. Right side of the screen is actually your left side. So left leg pain would be presented in this patient. This one's a little bit more difficult to see, but this is a very lateral herniation. So you can get a very lateral herniation here or a central herniation. These lateral herniations are super, super difficult. For one, they are ridiculously painful because there's the dorsal root ganglia lives there. That's where the nerves, the sympathetic bundle of the nerve sits there. So when you have a far lateral herniation, these patients come in and they're way different than normal sciatica patients. These patients are like, you got to cut my leg off. I'm going to jump off a bridge. This is like ridiculous pain, okay? And so imagine this patient coming in, presenting 1 week in, and then trying to talk them out of like, hey, listen, don't jump off a bridge. We got to wait on this thing when they can't even walk or move. And the most difficult thing about this herniation here is that in order to get here, so you can make a little hole here, grab the disc here. But in order to get here, sometimes you have to take off 50% of the facet joint, which then leads you to having a fusion. So you have no choice. So these patients come in, they're like, my leg's hurting me. You got to cut it off. And we're like, well, you got to get a fusion. You got to get screws and rods for this. Because if you take off 50% of the facet, which is usually required to do this, to take this out, you destabilize that segment. So the patient may wake up and say, my leg's feeling great, but now their back is killing them because now they have a wobbly facet. So these patients typically have a concomitant fusion, which, going back to several slides before discussion, like this just adds to the the prevalence of now potentially getting another fusion again. So these are pretty typical or tough herniations to treat, but also tough herniations for patients to go through. So, how do you do this? Patient's prone, usually on a Wilson frame. Again, it's a microscope, a little bit of the C-arm, about less than an hour. You go home the same day. Post-operative course, we tell these patients, you have to kind of stick with doing baby steps for about 6 weeks till that area scars in. There's about an 8 to 10% reoccurrence rate, meaning that patient does great and within 2 weeks has redevelopment of leg pain, typically because of they went back to activity too quickly, or they went back to work too quickly and they had a reoccurrence. You can basically go back to life normally after 3 months, and the rate of reoccurrence at that point, if nothing's happened at 3 months, is pretty low. So what do you think from a post-op perspective? Patients that have this operation and have still persistency of leg pain is not normal. Worsening examination, weakness is not normal. And then you have to obviously look for wound issues and then spontaneous development of headache. So you can get a cerebral spinal fluid leak that you don't acknowledge. And then, a week later, patient calls the office, is like, every time I stand up, I have this extreme headache. If I lay down, it goes away. Well, that's kind of classical of a cerebral spinal fluid leak. And then obviously one of the biggest things we look for is because most discectomies occur at L4, L5, and L5S1, you really do look for foot drops. So dorsiflexion, bringing your toes up to the sky. And that becomes super important because you can't walk well if you don't have dorsiflexion of your foot. you drag your foot. So that becomes a big issue for patients. So you don't want to miss that. And sometimes that develops afterwards, few days, because of maybe a hematoma. So when that occurs and you see that foot weakness significant, you have to kind of get back to surgery quickly in order to save that nerve. So here's the meat of the talk, is about fusion. So, when we fuse these segments, how do we do them? How do we choose which way to go? Do you go A-lift, so anterior, so through the belly button? Do you go lateral, which is the patients in the lateral decubitus, as well as O-lift or ATP, which is anterior to the psoas? Do you go posteriorly, which is kind of the more classic gold standard, where people do a PLIF or a T-lift. So these are all requiring cages to go inside the vertebral disc space to fuse that segment. So what you're trying to do is you're really trying to make L4 and L5, for instance, one bone. So you're trying to weld those two segments together. So what do we use? We use a bunch of screws. We use all these devices here, which are interbody devices. And you can tell that, this one's enormous. This is an A-lift anterior interbody cage versus a T-lift. The surface area is larger, the implant's larger. And so the larger the implant, the more likely that segment is to heal, because you're just encompassing a larger surface area. The screws are utilized so that there's for the first 6 months, no significant movement across that area. The screws, and the cages for that matter, are pretty worthless once that segment fuses. You could actually take them out if you really wanted to. Well, the screws you could. So obviously this is just a bird's eye view of what the cage looks like. So this is an A-lift cage, so you go through the belly. This is a lateral cage, you go through the side. And these two cages here on the bottom are the ones that you go through the back with. And you can tell that they're at least 50%, if not more, smaller than these up here. So increased fusion rates with larger cages. So what's the goal of fusions? Again, you can treat a variety of issues, but particularly patients are having fusions most often because they have leg pain, but also have a lot of back pain. And obviously we're not fusing patients who have not gone through the algorithm of trying everything under the sun. And typically I tell patients, like, you got to hang in there for 3 to 6 months with this stuff before we make a decision on surgery, because sometimes these one surgeries are not your last. So how can you go through these? Well, again, you can go through it through the belly. You can go through it through laterally. Again, you can go through it posteriorly. There's a number of ways to do it with the same outcome. I think there's some increased advantages to putting these larger cages in, and also restoring, lordosis. So these big cages have a lot of lordotic curvature in them, and these smaller cages don't. So what's the thing to consider going through the belly? Well, you definitely need someone to access that retroperitoneal space. So you need an access surgeon. That's the most important. There are some spine surgeons in the country that do these approaches by themselves, but it's very, very uncommon these days, particularly on the legal perspective. So we always have a vascular surgeon in there. You want to think about calcification of the great vessels. You want to think about their, whether or not patient has peripheral artery disease. You want to have these discussions with patients who are young, particularly males, of retrograde ejaculation. So this is where, you have to have this conversation that if you haven't had children yet, you may want to consider doing sperm donation because of retrograde ejaculation. You also get a bigger footprint for the fusion, again, with the device, and then you can restore significant lordosis with going through the belly. So most important thing when you go through the belly is these vessels. So you get the inferior vena cava, and then the inferior portion of the aorta, which then split, and all this large blood vasculature here is all ending at the bifurcation, so at L4, L5. And so the vascular surgeon has to take this area and mobilize it to see L4, 5. And any type of injury here, and the injury rates are about 1 to 3% across, globally, but an injury here can be fairly catastrophic. So these are super high intense cases in terms of stress level, but they, in my opinion, are also the best operations to get to the goal that you want. So this is a patient here who obviously had a 2-level front and back, as we call 360 fusion. You can see these large cages in the front, a couple screws harnessing them, and then they're just posterior stabilized with screws. So now these two segments are no longer going to move. And the goal is to make this bone here attach to this bone through basically a bone spicule through those two segments. Now you can tell that this segment here is perfect, right? But this one here, within 10 to 15 years, will not look like that, because there's going to be extra forces that are going to go through that level now, and that's just the name of the game. You know, that's just how this works, is that increased strain now to the next level above a fusion. So this is where, you know, lumbar disc replacement, that's where this thing starts to come, because now if you do a lumbar disc replacement, it's not a fusion. You stay mobilizing across that segment. It decreases the adjacent segments, you know, to get overwhelmingly overworked, and there's lesser chances of developing adjacent segment problem. So we'll come back to this. So this is a patient who had prior surgery at L4, L5. The facet got unstable. She slipped. And so now she has a grade 1 L4, L5 spondylolisthesis, back pain, leg pain, and you know, she gets a 2-level fusion. So front and back. You can tell that the graft doesn't look so intense here because it's a femoral allograft, so it's basically bone, not titanium. So what do you do for these patients post-op? What are you looking for? You know, you advance their diet as tolerated. You really are looking for possible ileus issues. The longer you're in the belly, statistically speaking, the more increased chances of ileus. So when I first started, you know, I've been around for almost 20 years now. When I first started, everyone got an ileus because we were so slow at it. We'd be in the belly for, you know, upwards of 2 hours. Today now, we can be in and out of the belly in 45 to 60 minutes. Hardly anyone gets an ileus. So the ileus is definitively correlated to how long you're in the belly. And then so the other things we worry about, particularly in the post-op, is that if there was an arterial or venous injury, even though like everyone says, hey, it's okay, we cleaned everything up, there is a 23% increased chance that if you hit the right or left iliac, particularly the left iliac vein, that there's a 23% increased risk of getting a DVT. So you have to be pretty cognizant about lower extremity exams, swelling, you know, numbness, etc., discoloration. And so these are the red flags, right? Cold extremity, significant pedal edema, you know, nausea and vomiting for the ileus, and then worsening leg pain than what they came in for. And that typically is hardware mediated. So patient goes, has his procedure, wakes up, they're like, my leg or my legs are killing me. You absolutely need to figure out whether the screws are in a wrong place or too close to the nerve. Even if the nerve is in close proximity to the screw and the screw is just out, you know, a millimeter, even though it's not even touching the nerve hates that stimulation of that metal being around. So you really need to be cognizant about the leg pain and really check all the boxes to make sure hardware is not an issue. So lateral versus oblique. So this is where patient goes on their lateral decubitus and you enter through either definitively laterally or oblique, which is called anterior to the psoas. And so the difference here, and some of you who are in the room, you know, the lateral is when you put all those leads on and everyone's always checking for their nerve, like is the nerve too close, is it too far? So you're really worried about, at that point with a lateral, you're worried about the lumbar plexus. So all these spaghetti strings that come out of the spine, they converge in the psoas muscle. So you can get a lumbar plexus injury if you don't monitor those nerves. And you definitively get into an injury if you're doing these things laterally at L4, L5, because that's where the abundance of the plexus is. And more definitively is that's where the general femoral nerve comes to then go into the, into the leg or the sciatic nerve in the butt. And the reason for the discussion about the general femoral nerve is that if that gets irritated or it gets injured, these patients have, number one, hip flexion weakness that may or may not come back. They have an extraordinary amount of numbness in their thigh. And that can be avoided if you do an oblique, because if you do an oblique, you don't have to go through the psoas. You come underneath the psoas, and the nerve doesn't get stimulated that way. So the only difference in the two is that doing it obliquely, you have to be a little bit of a cowboy because you are seeing all these, the vessels. You're seeing the artery, you're seeing the vein. And when you do a lateral, you really don't see any arteries or veins. So that's why not many obliques are done, just because people don't feel comfortable going into that retroperitoneal space by themselves unless they have an access surgeon, and getting an access surgeon is not very easy in most of these hospitals. So what do you got to think about with these patients? Well, you do have to think about similar stuff that you would with the belly. You got to think about where the vessel is, where the kidney is. You're worried about the ureter. As you go up the spine, L3-4, L2-3, the ureter becomes more and more lateral, so you have to be cognizant of that. And the most thing you need to be worried about is the general femoral nerve, because that can be significantly difficult for the patient. So this is just depicting, the cage that can go in laterally. This is a device that we use to enter the disc space laterally. And so here's just a picture depicting where the incisions are. So if you do it laterally, these are the incisions. If you do it obliquely, the incisions come a little bit more into the belly. You're kind of getting into the same area, except for when you're doing it obliquely, you see a lot more. You see a bunch of muscle. You see the peritoneum, the bowel. You see the left iliac vein. You can palpate the left iliac artery. You can palpate the aorta. So it's a little bit more stressful doing it through the oblique approach, but I do think patients' outcomes are significantly improved, and it's the only access that you can get to L4-5. People don't do the lateral at L4-5 because of that general femoral nerve problem. So here's just a picture depicting a L4-L5 axial view. Okay, so this is a bird's eye view. You get the disc or the bone is here, the spinal canal is here, but here is the iliac artery, the iliac artery on the left side, and this is another artery that sits on top of that. And so here, this is the psoas muscle. So you're actually trying to come underneath that to get to the disc space. So obviously here, if you looked at this, you'd be like, well, this doesn't look like a good idea because the artery is right there. But here's the same depiction on a different patient where you see this corridor is nice and open. So again, this is the vein actually this time, this is the artery. And so there's a nice corridor, so you just hug the psoas muscle, you push it out of the way, and then you can enter the disc space that way. So here's a patient who had an obvious L2-3 lateral. The cage went in perfectly. You can see how much compromise there was in the narrowing. And so the patient presented with, at L2-3, presented with anterior thigh pain that went medially to the knee, which makes sense because that's how the L3 nerve travels. So that's the majority of how we figure things out, is when we ask patients about their leg pain, we say, hey, where does it go? Where does it end? And then we know the dermatomes of what that nerve goes, and scientifically it makes sense. Here's another patient who had a spondylolisthesis of grade 1 here, failed conservative measures, but this patient was done obliquely versus the last one was laterally. So you kind of get to the same, the same outcome, same picture, but just done differently. And you can tell that if you go back here, so the slippage here now is almost back to normal, maybe off by a millimeter or so. So post-op care for these patients are quite similar in, the ileus and potentially even the DVT risk. Most important, again, is the general femoral nerve problem with these oblique and lateral approaches, and then the ureter. So if you're handling these patients post-op, number one, you want to check for urine output. Obviously, if you had a ureter injury, you may have less urine output because you only have one working. And then secondarily, the most classical sign is that these patients who have this done obliquely or laterally, their incisions are atypical to be painful. So a patient presents with a lot of abdominal flank pain after these procedures that is somewhat out of the ordinary. You have to make sure the ureter's intact. This here is the TLIF approach. So this is a posterior approach. Patients laying prone. This is kind of the workhorse of lumbar interbody fusions across the country, across the world. They're my least favorite cases because these are the largest case series typically that develop non-union. So you're trying to fuse the back, but it never fuses because you're using a small implant, and you're not, visualizing as well you would visualize in these, bigger cages. So your disc prep is less. It's just in my opinion, lesser of an operation with not as great outcomes. But it is the workhorse of spine surgery, and just not my favorite. So this is more often than not, this is a direct visualization. So when you're putting those big cages in, you're not looking at the nerve per se. You're just, you're hoping that you're indirectly decompressing it. With the T-lift cages, you're directly taking off the facet, you're directly taking off the ligament, you're directly looking at the nerve to make sure it's not compromised or pinched any longer. So obviously with that, because you're not in the belly, you don't have much of a vascular risk. You don't have an ilius risk. You don't have a ureter. All that stuff is in front of the spine, so you're in the back of the spine. So those things are not much of an issue for you. So here's a patient who had an L4-5 slight slip. Here you can see it looks a little bit narrowed. So we went in, and patient had right side of the screen is the left side of the body, but had left leg pain. So this is the facet joint here. So we take off this whole facet joint, decompress that left nerve, and the patient has, relief of nerve pain. And you would ask, well, this here looks like this here. Why does the patient not have right leg pain? I don't know. I'm not really sure. It's just how it is. It typically is unilateral, so that's why we go typically on the affected side, take off that facet, take out that ligament, and decompress the nerve. So this is just a depiction of using a retractor, a tube to get down into the area posteriorly, and through landmarks, obviously knowing where the superior and inferior facet and what's known as Cayman's triangle, you do a complete facetectomy, and then you put this cage in. The cage actually slides along or in between the nerves, so you have to be super cautious when you're doing that as well. But that's the reason for the tube, so that you can stay in a good plane that the nerve is usually outside of the tube. For those that use tubes, some use a retractor, but a lot of the younger fellows coming out are using all these tubes. So here's this, cage, T-lift cage that was all done posteriorly. And those markers there are, metallic markers, titanium markers inside the implant. The implant's actually plastic, so PEEK, polyethylene ketone. And so a little bit more flexible of a cage, not as rigid. Some would describe using PEEK may lessen the chances of getting adjacent segment problems. I'm not sure I believe that. There's articles to say that it's not really that big of a difference. So post-op with these patients is basically looking for any type of worsening pain, numbness. Again, the headache thing is important as well. Positional headache. I lay down, I have no headache. I stand up, there is a headache. Again, when you're looking through these small holes, sometimes you can't even tell that you poked a hole in the cerebral region in the dura. So monitoring for headache. And then again, persistency of a lot of nerve pain, leg pain is a problem. The patient shouldn't have. If it's like, oh yeah, my leg aches me a little bit, that's one thing. So you just had surgery on that area, but like significant pain in the leg, that's a problem. So you have to check the hardware, make sure the cage didn't pop or come backwards. So fusion long term, like I alluded to, there is increases chances after a fusion of developing another problem. I'd like to tell you that those problems don't come, until 10, 15 years later. The literature says that, but it happens sometimes very quickly. I mean, I've had patients who come back a year later, 2 years later with already significant issues. The other thing you have to worry about is non-union or pseudoarthrosis. So you're trying to achieve a welding job at that level, and then the thing doesn't heal. And there can be a multitude of reasons why that is. The most common are just bad bone, right? As we get older, we have osteopenia, osteoporosis. We don't have as good of osteoblastic builders to build the bone. And then the number one reason of a non-union or pseudoarthrosis is smoking. So the actual nicotine inhibits bone growth because it decreases vascularization to that area. So smoking is a huge issue. And then, obviously there are other comorbidities that lead to healing issues as well. So the A-lift, through the belly is done obviously supine. This is a prone position. This is what you would do for like a T-lift. So everything, small cage going through the back. This is obviously an oblique. So patient is in a lateral decubitus. So this is how we enter laterally as well as obliquely. This is just a picture of an actual tape job for these lateral positions so that the patient doesn't obviously roll one way or the other. It's how we bring in the C-arm for purpose of localizing the correct levels. And then ultimately, after we put these cages in, you have to fixate them most often. So you have to harness them through the back. So we do this typically in a minimally invasive fashion. It increases the chances of it healing versus standalone significantly. And we used to put these in by hand percutaneously. Now with all the navigation and robotic technology, it's significantly improved faster. So this is how we used to do it old school wise. Would we make all these landmark x-rays with C-arm. We would map out where the pedicle is. And ultimately, we're trying to target the pedicle, which is these red areas. So that's where the screws are going to come through, both on the lateral and on the axial. And so by hand, if you were good, you could throw in 4 of these screws in probably about an hour to an hour and 20 minutes. If you were, you have to be pretty good to do in that time frame. And now with the robotic navigation type arena we're in, we can put 4 screws in gosh, like 15 to 17 minutes. So patient doesn't have to stay under anesthesia long. And there's decreased or improved pain scores afterwards because you're not basically in the spine for too long. So this is how we used to do it, where we'd with a jam sheeting needle, we would target the pedicle, make sure we're equal on the lateral, and then we would punch these things in with a hammer, put a K-wire through it, just a whole bunch of steps. It's the same thing, targeting that pedicle at the vertebral level. So this is what it would look like without the robot. And so what has the robot done? Well, the robot now brings this thing in and basically does all the work for you. I mean, it's that easy. And so you can teach anyone to do this. It's an arm that actually trajects you in the correct direction, which you then confirm it's in the correct direction with X-ray. It actually does nothing of the surgery for you. You're still doing everything. It's just basically a GPS. But again, the amount of time that it takes us to put in 4 screws basically would blow your mind. It really almost looks like you're in another world, because you're like, wow, you're sticking this huge knife down this tunnel and you're crossing your fingers hoping that this goes in the right place. And it's just kind of a little bit mind-boggling when it first started. Now it's so used that it's almost like, I don't even know how to do this if the robot's not there. So here is this is the robot arm here. So what ends up happening in the surgery is that you get a CAT scan preoperatively, then you take 2 X-rays in the room, and then those 2 films magnetize. So the CAT scan has like 14 billion dots on the bone, and then the same thing happens with the X-rays, and then those dots magnetize, and then the robot knows where it is in space, and then you just tell the robot, I want to go to L2, and it goes to L2. I want to go, to the universe. It brings you wherever you want. But that's how it marries the image in, and that's how it knows where the patient is. And there's a variety of different robots. There's, Globus has one, Medtronic has one, Stryker has one, everyone has one. And so it just really depends upon where you train, which one your hospital bought, but they're all, guiding you towards the direction you want to be at. They are not doing any of the surgery for you. But what's next in spine? I think probably 10 years from now, we probably will hear about minimal fusions being done and more disc replacements being done. And so this is where spine is at today, in that this is what you should have. You should avoid the fusion. The only problem with this is that it's not for everybody. You really need to know definitively what everything looks like. You need to make sure that there's not circumferential arthritis. And the most important thing, or most important three things are, number one, you need an access surgeon, so you got to go through the belly for this. Number two is that not all insurances cover this. And then number three is that not all surgeons know how to do this. So there's very few in Connecticut that do this well. Across the country, there's several. But at this point in time, if you really wanted to have a disc replacement, you'd have to pay, for the most part, pay cash, because the insurance companies are still looking at this as experimental, believe it or not. And so that's one of the biggest hindrance of this procedure. But I think with time, this will be the gold standard, and fusion will go away. What's the time on that? I have no idea. So here's a patient, 51-year-old, active female. Is actually a triathlete, is also a professional equestrian rider. So she had lower back pain, and she got a disc replacement. She was back on her horse within 6 weeks. With a fusion, I don't know if she's back on a horse within a year. This is another patient, 54-year-old, actually a individual who I come to know for a few years, who was just putting off, who ended up having a disc replacement, and went back and did like one of these Spartan races, I think 2 months later. So it is significantly changing the spine world in terms of back pain. I threw this picture in here because, like, this patient here has a significant arthritic facet, and over here is very normal facet. So if you did a disc replacement in a patient that had a facet like that, you're doing them no justice, right? So when we do these disc replacements, we tell people, hey, these posterior facets have to be pristine. Otherwise, you're not doing yourself any good by doing a fusion, because you're still going to have pain because that joint is no good. And that's it. So I'm happy to take any questions, or give you some more insight on any other things that you may think about. Yeah.
So when you're out in practice and you're an established spine surgeon, and then this new technology or new procedures come around, how do you train yourself to be able to do a disc replacement?
Yeah. So I think a couple things. Number one is you can't teach a old dog new tricks. So the more mature surgeons, they're not even thinking about it. Yeah, they're not even thinking about it. Even if you are a young fellow, if you're a fellow presently and you're at one of these fellowships, depending on which one, there's very few in the country that actually focus or have a focus in lumbar disc replacement. Like Cedars-Sinai is very huge into it. Texas Back and Spine in Texas obviously is, but very few. So most often what ends up happening is that they come out of fellowship, they really don't know it, but their mindset is like, well, I want to think about this. So if you don't get it in the first, let's just say 4 to 5 years of practice after fellowship, you don't even think about it. It just becomes out of your, your realm of options. And it's very, very few mature surgeons are doing this at all. All of the lumbar disc replacements, for the most part, are done by young surgeons these days.
So we can take a decade after the technology. So you learn it in your fellowship, you go out into practice, if that's one place, and then the next wave comes, and then that's 4 more places. So for it to proliferate as a standard of care across the country, it could take years and years.
Years and years, yeah. So the lumbar disc replacement, the first one done was like 1968. It was done in France, got adopted in the US in like the mid-90s. There's a whole bunch of them done, not FDA approved. Finally got FDA approved 2001. But because the literature is so bad about it, that's why the insurance companies are still so negative about it, because the literature is still representing those outcomes in the mid to later 90s, and then even the early 2000s. So they're still going on that data, and that's why they deny these procedures. But to your point, if you're not exposed to this, then you can't do them. If you can't do them, we don't have data. If you don't have data, you can't do anything, right? So that's why a lot of patients who have these lumbar disc replacements, they either got them because they got lucky. Number two, they had a team surgeon, et cetera, that fought for them, or number three, they paid for it, and so the numbers are one level disc replacement, cash, if you're lucky, runs you about 60 to 75,000. 2 levels is about 100,000, and then 3 levels you're looking at like 120,000. Yeah. So right now the data says plus 32 years because we only have it. That's all we have. So you can't say 40 years because they haven't been done in 40 years of data. So so that's that. And those numbers are not reflective of surgeon professional fee. If you have to break it down, say one level is about 70,000, 60,000 goes to the hospital. Yeah. Any other questions? Yeah.
Any data on rate of failures done of the discs in the last 20 years?
No. I mean, the failure is based upon more often than not, basically the reasoning to not have had the procedure to begin with. So the failure is on, well, they didn't really check the facets, or they didn't put it center. So you can imagine if you put these artificial discs in there and they're not perfect, center, they're off to the left or off to the right. You can imagine how then you start to have kind of a tilt in your back. So if it's off to the right, you may be tilted left, and now you have another problem, right? So if you're not perfectly center and the carpentry is not done perfectly, then that becomes a huge issue postoperatively. The other thing I'll mention too is that, so in order to do so you take a patient, you have a lumbar disc replacement and a lumbar fusion, right? You can have either one. You go and have the fusion done. The surgical time to do that ALIF could be 45 minutes. The surgical time to do the lumbar disc replacement is probably upwards of an hour plus, so longer procedure because it needs to be perfect, right? So the other issue, to go back on that, is that if you took the two operations, one is very intrinsic, one's very carpentry, you have to be perfect, versus the fusion pays 2, if not 3 times more, right? So now, unfortunately, medicine is a business, right? So now that's the other hurdle, is that surgeons are like, well, I'm going to do this procedure, I'm going to get paid 2 to 3 times more than if I did this, even though I feel like this one's better procedure, right? I mean, that's just the name of the game. I hate to say it, but that's where we're at right now. And the numbers, when you get into that kind of arena, they're staggering if I told you them. You're looking at like somewhere between like a $3,000 procedure and a $15,000 procedure. So that's another curveball of the whole scenario as well.
What do you need from your nursing team in these procedures?
So it's not so much the nursing team. Well, number one, the nursing team does help us, get to the point of like some of these complications, right? Is there a lot of nerve pain, right? Is the motor exam normal? And this is like definitive weakness, right? It's not like, oh, patient can like poor effort. This is like, move your foot. It's like, I can't move my foot. And typically the foot is like this, right? And they can't even flicker it back. So knowing that motor exam, knowing the difference between severe pain and, just having post-op pain, obviously. A lot of that is happen upon experience, right? I've seen this a million times, etc. But what's most important in these patients is getting them to mobilize quick. So getting them out of bed quicker lessens the chance of ileus, obviously lessens the chance of DVT, particularly in those patients who've had maybe a venous injury during the operation. And I think that the most important transfer is that initial transfer from the OR to the PACU, right? Because if you don't know that there was a venous injury, then you're not going to be, thoughtful of, is the calf swollen? Is the calf painful? Is the ankle swollen? So that transfer of care is the most significant. So then you guys can relay that to the floor, and subsequently we can watch for the obvious classical issues with that. So I think that's the most important. But other than that, it's mobilization, obviously pain control, and then a lot of it has to do with reassurance too. Like, I know you're in pain, this is painful, but it can be difficult for nursing, because if you don't have the experience, some of these patients can come out of the OR and they're like, the pain is just absurd, and then I tell this story all the time, like, I would rather rather deal with 70 million 70-year-old females than anybody else. They have no pain, they have no issues, they're like, they can do whatever they want, versus like the 30-year-old female or 30-year-old male. Those, those patients are just, they're built different. They're just built different. And so, yeah.
In, I guess, the society that we live in, and with, the standard of treatment kind of getting with 3 to 6 months before you consider surgery.
Yeah.
Do you encourage like weight loss, and do you think that that helps with their pain, like especially with the GLP-1s and all that kind of stuff? Like, is that a direction you encourage?
Yes. Yeah. Yeah. So the true answer to that is no. Yeah. The true answer to that is no. And so, what I typically tell patients, because I mean, that's a common question. Like, patient will come in and be like, oh, I know if I lose 50 pounds, the likelihood of you losing 50 pounds, let's face it, it's not going to be, I mean, the common story is like, well, I can't do anything because I have back pain. So am I going to lose weight, right? Yeah, the GLP-1s are wonderful now and they're super helpful, but that still doesn't change the structural phenomenon, right? So you can lose as much weight as you want. I typically tell patients the reason to lose weight is, number one, because maybe the best procedure for you is through the belly or through the side, and doing that when you're large has an increased prevalence of risk, right? That's number one. Number two is that I can't tell you how important it is to be psychologically, at your best. And for the most part, I think when we do lose weight, when we are, fitting into our clothes better, psychologically, we just feel better, right? And so that's super important in that post-operative period to get back to normal. If you have a whole bunch of stressors, you're in depression, maybe you still have some pain afterwards, and it's not as best as you would want, like a 2 out of 10 pain to me is a game changer. I'm like, wow, you won, right? But these patients that are maybe a little bit depressed, maybe a little anxious, that 2 out of 10 is still so significant for them. So sometimes, losing weight in that area almost makes you just feel better, right? Like, I feel better about myself, my clothes fits better. So I think that's the importance of the weight loss. But I tell everyone all the time, like, don't lose weight because you think your pain's going to get better. It's not going to get better. Lose weight because you want to do it psychologically to help yourself. And number two, to help us do the better procedure for you, right? So there is kind of a BMI cutoff for doing some of this stuff, particularly in our system. We tend to say 40 and below is okay, or decreased risk. 40 and above, there's increased risk, right? And for a lumbar disc replacement specifically, is that the data shows that BMI of greater than 35 increases risk of the implant failing. So if you have a BMI of 35 or greater, we just tell you you can't, right? And we just did a guy last Wednesday who had a BMI of 33, and I just tried to tell him, dude, don't gain weight. Like, you're right there. You got to go the other way, And so the data shows that the biggest implant failures, if they do occur, are 35 BMI and greater. Yeah.
Now, what are these surgeries are getting trending towards the outpatient surgery centers versus what are these?
So it's going to follow the trend of outpatient joints, whereas right now collectively there's probably about 75% of joints are being done in the hospital, 25 are being done outpatient. The numbers in spine are probably half that right now, and so like a one level lateral, one level oblique, one level T-lift can be done outpatient. A decompression discectomy can be done outpatient. Multi-level spine fusion, probably not a good idea because of a pain perspective. And then obviously doing it through the front of the belly does increase the risk. So doing one level at L5S1, I think can be statistically okay on the risk side. If you're doing 4 or 5, you probably shouldn't do it outpatient from the front. Even though there's centers around the country doing that. I think it's relative risk. So belly stuff is still being done in-house, inpatient, albeit the trend to do it outpatient is right around the corner. Yeah.
How are you addressing unrealistic expectations from the patient population? Because we know that about 40% of all workplace violence is actually for that unrealistic expectation.
Yeah.
They're coming out to those providers that are doing those procedures.
Yeah.
Last year, there was 23 surgeons that were murdered because of the unexpected outcomes.
Yeah. Yeah. No, that's the reality. You know, that's the reality. And I tell you, my own experience is that, you know, I've been doing this a long time, so I've met every type of, you know, different patient. And my typical lines are, number one, you know, if you're having a 3 out of 10 pain, don't have surgery. If you're having a 7, 8 out of 10, let's talk about surgery. You know, and then I tell those patients, if your pain's at a 7 or 8 out of 10, the goal statistically and in the literature with fusion is improvement of 50 to 70% of pain, right? So, you know, you're not getting 100%. So if you have, you know, an 8, like we're going to get you down to like a 4, maybe a 5. And if you're lucky, a 2 or a 3. So you have to set that expectation, like no surgery is done with 0 pain. It just doesn't happen. And I usually say, if you do come back with 0 pain, it was a miracle. Good for you, right? And then the most important thing in my opinion is that, like, I never argue, never, because that's where that stuff comes in. Because the argument is about pain, okay? And you can talk yourself out of pain. But the second argument is narcotics, right? These patients are always seeking narcotics because they're in pain, right? And there's a difference between the patient who seeks narcotics because they're in pain, right? And you can usually visibly see that, right? Patient doesn't look well, and, you know, maybe, you know, thriving in the chair, versus patients come in, they walk down the hall, they look great, they sit down, they look fine, and they're contemplating pain, and then they're just seeking narcotics. Those patients are the worst because ultimately they are just now addicted, and talking those patients out of, like, hey, listen, you got to get off this med, sometimes can be super, super difficult. So I'm not sure that, number one, I answered your question. Number two, I'm not sure there's a perfect algorithm to that, but for the purpose of what you just said, I try not to argue with these patients, you know, about the narcotic thing. I try to be, you know, as nice about it as possible. And I'll be honest and say that sometimes I'll just give them the drugs, you know, because I don't want that to happen. Because there's a whole bunch of staff, right? The nurses up front, you get the medical assistants, and they get the heat more than I do, right? Because they're already coming in belligerent in the whole 9 yards. So I'm just trying to kind of, you know, iron things out. But I'm not sure that the way to go is to argue with these patients, particularly in this day and age where things are just kind of crazy, you know? So what I usually do is I try to, you know, figure out something that they will like in terms of winning scale. And then number two, I always get someone else involved. So like, I'll be like, well, let's see a pain management, you know, person. So then multiple of us can take on this dread, you know? So that's what I do.
Setting expectations.
Yeah.
Do you do anything with like complements to the pain regimens, complementary aromatherapy or physical therapy, all of that comes along with it? Are you utilizing anything like that to reduce the opioid usage?
So yes, the answer is yes. So we use a lot of like, you know, like stimulation stuff. So there's like visual acuity things now that you can wear. So you can actually, basically it's like a headset that you can watch. It's basically programmed for pain response. You can see, like, you know, beautiful Caribbean pictures and things of that sort. There's, you know, like TENS units that we use for pain control. We try to avoid those other pain treatments, such as like stimulators and these things, just because they're just not well documented to work. And if they do work, they only last like a year, 18 months. But we do initiate a lot of like physical therapy, aquatherapy, stimulation devices, these visual acuity things. And then we try to use like non-opioid other medications, right? So things like, you know, muscle relaxants, you know, gabapentin, Lyrica, if that's a case for pain modifier or nerve injury. But there's not one that's like the most helpful, you know? So,
Thank you so much.
yeah, thanks.